Good evening, everybody. Welcome today to the RSSDI Social Initiative Program, which happens every week between 7:30 p.m. to 8:30 p.m. This is our 22nd program continuously. We had last week we went there with you because we had an annual conference of the Research Society for Diabetes in India, and taking the initiative forward along with the social media team. Now I have three stalwarts with us to take the session forward. Today's session is all about I've been diagnosed newly with diabetic. What next? I have my diagnosis with diabetes. What should I do? Or I did a routine blood glucose. This is my value. It shows I'm diabetic. What do I do next? To take this forward, we have none other than Dr. P.V. Rao. Dr. P.V. Rao is MD, PhD. He's been the past president of RSSDI, now presently the patron for RSSDI. We're very proud of you, sir. He's been secretary for the RSSDI for more than 15 years. He's now presently working in proteomics, trying to develop a lot of point of care devices, but nonetheless, his heart is always with RSSDI. Next, we have none other than Dr. J.J. Mukherjee. Dr. J.J. Mukherjee is an endocrinologist from the Apollo Gleneagles Hospital in Calcutta. He was trained in the UK, has a lot of publications to his credit. He's a key opinion leader in this country, and also recently delivered an oration at the RSSDI. Dr. JJ, we welcome on to the program. Now, to take this program forward, we have none other than Dr. Professor L. Srinivas Murthy. Dr. Srinivas Murthy is an undergraduate and a postgraduate teacher. He's been in the field of diabetes and medicine for the last 25 years, runs a center at Bangalore. He's been very keenly involved in all stages of clinical research. And now he's also the national executive member of the RSSDI. To take the session forward, now I request Dr. Srinivas Murthy to go ahead and continue with the topic. I'm diagnosed with diabetes. What next? Over to you, Srinivas.
Thank you, Sanjay, for the kind introduction. Good evening, all. Welcome to this 22nd episode of Diabetes Bytes by our RSSDI. Today, we have none other than Professor P.V. Rao, who's well-versed, well-experienced clinician. We have Dr. J.J. Mukherjee, who's seen both East and West. He's worked more than 2 decades in Singapore country with organized practice, and he's surviving even in our country. That shows the success story. Welcome to both of you, sir. So we know the problem when we diagnose somebody with diabetes, there are n number of questions, and usually we spend more than half an hour for the counseling many times to convince the patient that he's got diabetes. And today we try to enlighten in a limited period of about 60 minutes. We will try to enlighten our viewers, our colleagues about the basics about a newly detected diabetes, what it goes through, and what are the points we should look at. So first thing, sir, P.V. Rao, sir, I would like to ask you, what is the criteria to say somebody that he's got diabetes today and he's going to be a diabetic and we need to initiate treatment, sir?
I will first start with the criteria for diagnosing diabetes. We had several criteria earlier, but now almost everywhere, all over the world, in India and America and all over the world, we follow same criteria. There is no controversy about diagnosing diabetes nowadays. So if somebody has blood sugar in fasting at 7 a.m., I'm adding that particular condition 7 a.m., not the fasting later in the day. Suppose somebody has a fasting blood sugar done at 7 a.m. in the morning, and the blood sugar is more than 125 milligrams in fasting, it is diabetes. So if the blood sugar at 2 hours after a meal or after breakfast, after a glucose load, if it crosses more than 200 milligram per deciliter, then it is diabetes. So 125 and 200 are the numbers given by most of the country guidelines all over the world. But people earlier used to have different criteria, but now whether we like it or not, all of us have to follow this particular criteria of diagnosing diabetes. And then there are other conditions like preclinical diabetes, where the fasting between 100 and 125 is called impaired fasting glucose, and a 2 hour value between 140 and 200 is called impaired glucose tolerance. That is also a preclinical diabetes. So people with preclinical diabetes may develop diabetes in next 5 to 10 years. So that's another condition. So we used to have several other issues, but gestational diabetes is one condition where the criteria of diagnosing diabetes has still been not settled. People have different criteria, but international classification, international diagnosis of gestational diabetes during pregnancy. If somebody develops diabetes for the first time in pregnancy, and if the blood sugar is in impaired glucose tolerance level, that means if the blood sugar at 2 hours is 140 to 200 or 140, then it's called gestational diabetes. It need not cross 200. But
Right.
but pardon, any
No.
other?
Go ahead. No, I think
So,
you're talking about the special population also. I think the
mm,
basic criteria we should remember. Now, Dr. JJ, we have got a question for you that why the criteria were brought down. Earlier it was 140 fasting, now it's 126 as Dr. Professor was telling. Now, why do you think this is brought down and what is the reason behind this? Because a lot of people think the industry is brought down so that more number of people become diabetic per se. So is it true?
I think this question may not be right to discuss with the general public. It's a very nice
Okay.
topic to discuss amongst us in a research setup. Because as
Correct.
Professor Rao just mentioned, fasting 126 and above and PP 200 and above. The other thing, Dr. Rao, which is he was mentioning it about H-glycated hemoglobin, HbA1c. That has also
Yes.
now been included in the criteria. If it's 6.5% and above, twice, then you can diagnose diabetes. So the problem is now I'm going into controversy. So before I go into controversy, for everybody who's listening, जितने भी लोग सुन रहे हैं, எல்லாரும் ஒரு hear பார்க்கணும். Clear cut. Fasting more than 126 and above, PP more than 200 and above, HbA1 is 6.5% above. Two of them have to be abnormal, diagnosed diabetes. Now we are going into controversy because Professor Srinivasa wants to go a little bit more into controversy. So if you take fasting, PP and HbA1c, all three of them do not speak the same thing. If you take HbA1c alone for diagnosing, suppose you do HbA1c twice, two times the value has to be abnormal, 6.5 and above. That may not diagnose all the people who are diabetic if you were taking 2 hours 75 gram glucose load value. The highest number of people who will be diagnosed is with the 2-hour PP glucose, 75 gram or OGTT. Now, 75 gram OGTT is not always feasible. I mean, in a big country like ours, where we have more than 7 crore diabetics and maybe a lot more who are undiagnosed, it's probably not possible to do a 75 gram OGTT. That's why the ADA came up with the fasting criteria. And initially, the fasting criteria was 140. But when they did 140 and PP of 200, they realized that with fasting of 140, they were missing a whole number of patients who were getting diagnosed with a 2-hour PP. So they brought the fasting down to 126. But despite that, that still doesn't match. You still end up diagnosing more people with 2-hour PPG than with the fasting or the HbA1c. So instead of going into all this controversy, just to remember, I think we'll be discussing later on who should go for the test. Go for the test, fasting more than 8 hours or 2 hours after a meal, and see what your sugar values are. If you want to take home some message from today, as Professor Rao very nicely said, if your fasting is 100 and above or your PP is 140 and above, you've already crossed one threshold. And if your fasting is 126 and above or your PP is 200 and above, you have reached the destination of diabetes. Don't worry, diabetes is not a big condition if you take good care of it. And then get an HbA1c done. I think you won't get it done. Your doctor would probably ask you. And two values have to be abnormal to diagnose diabetes. So in a nutshell, fasting was brought down to match up with the 2-hour PP. But still, I think if you go into deep down the literature, Dr. Srinivasa, I think fasting should go even lower actually.
Correct. No, the very fact why I asked about this question is a lot of people have got this confusion. So it is very clear that if you cross 110 to 126, then you call it as a pre-diabetic. There is a major chunk of our population who are in pre-diabetic stage who can definitely by lifestyle modification prevent going into diabetes. That is the whole idea. And now coming to the next question, sir, who are the people who are at risk to develop diabetes, Dr. JJ?
I think every Indian is at a risk to develop diabetes, period, full stop. Okay, now if you want to go into criteria, I think age group more than 45, that's what the Western literature says. We don't have very hard evidence to go by, but I think we Indians developed diabetes 10 years earlier than the Westerners. So I would probably say, this is my personal viewpoint, about the age of 40, I think we should start screening. If you see the ADA criteria, they would say that certain ethnicity is more prone to develop diabetes. And if you see there, they say Asian Americans. And we in India are very prone to develop diabetes. So age more than 40 or 45, and one other risk factor, and I think everybody has a BMI more than 23. If you're thin, then of course not. So BMI more than 23. If you have age is more than 45 and you have a risk factor like say high blood pressure, or if you have lipid abnormality, and lipid is very common in us Indians, HDL is low, triglycerides more than 250. If you're a lady, you had past history of gestational diabetes mellitus. If you're having a sedentary lifestyle, now there you go. I mean, I qualify 100% sedentary lifestyle. All of us, majority of us, no, not all of us. I won't say majority, all of us. There are some of us who go to the gym and do exercise, but a big chunk of us are living a sedentary lifestyle. Of course, if you have a family member who's got diabetes, first degree relative, mother, father, brother, sister. So these are the various risk factors. There are risk scorings. There are risk scorings which exactly take these things into consideration. Age, male sex, blood pressure, first degree relative diabetes, lipid abnormalities, they give some scoring. But I think
obesity.
And obesity, of course. I think the basic take-home message is above the age of 45, I think most Indians should go, if you're not lean and thin, BMI 23 means just about average weight. You should do a fasting and PV blood glucose, may not do a OGTT, and then the frequency is once every 3 years. But if you had past history of gestational diabetes mellitus, or you're in the borderline range, as we discussed, impaired fasting glucose between 100 to 125, pre-diabetics, then you have to do annually, once every year. I'll stop here. We can discuss some more if you have any other questions.
Sure, sir. Sir, Rao, sir, what are the common symptoms where the patient has to be alarmed and he should reach out to a doctor for the testing? The common symptoms which the patient feels.
In the Indian population, about 70% of the people do not have any symptoms for suspecting diabetes. Almost previously, we used to say polyuria, polydipsia, and polyphagia. There are 3 polys. That means hunger, thirst, and urination is increased. That's a classical symptom triad of diabetes, but we don't see that often. Mostly 70% of the people do not have any symptoms. That's why we advise routine screening at 25 years or 40 years, some age group.
Correct.
In the Asian Indian population, that's very important. Routine screening.
So very important that you may not have symptoms, so get annually or once in 3 years, as JJ Mukherjee said, screening is very important. Proactively, you people have to visit a lab or a doctor and then consult and take screenings on a regular basis. That's very, very important message, because Rao sir has again re-emphasized 70% of Indians may not have a full-fledged symptoms. So very small symptoms, very subtle signs you may not pick up. So please be in touch with your doctor. Now, Rao sir, I want to ask you something. Diabetes lo enni rakal diabetes unnai sir? We are asking in Telugu for just for a change. Enni rakal diabetes unnai? I will, of course, in the due time, I will translate into English.
Diabetes రెండు రకాలు మోస్ట్లీ. డయాబెటీస్ టైప్ 1 అని చెప్తారు. అంటే ఎక్కువగా 15 ఏళ్ళు లోపు డయాబెటీస్ వస్తే వాళ్ళకి ఏంటంటే టైప్ 1 డయాబెటీస్, ఇన్సులిన్ తక్కువ ఉంటుంది, వాళ్ళు లైఫ్ లాంగ్ ఇన్సులిన్ ఇంజెక్షన్ ఇవ్వాల్సి ఉంటుంది అనమాట. టైప్ 2
Right.
డయాబెటిస్ అంటే ఏంటంటే ఎక్కువగా 40 ఏళ్ళు దాటిన తర్వాత వస్తుంది. వాళ్ళకైతే టాబ్లెట్లు ఇస్తే సరిపోతుంది, ఇన్సులిన్ అవసరం ఉండదు. 25 ఏళ్ల వయసులో అంటే 15 నుంచి 40 ఏళ్ల వయసులో రకరకాల కొత్త డయాబెటీస్లు ఉంటాయి. అది టైప్ 1 అయినా అవ్వచ్చు, టైప్ 2 అయినా అవ్వచ్చు. ఈ టైప్ 1, టైప్ 2 అనేది ఈ మధ్యకాలంలో చాలా వరకు దాదాపు అందరూ డయాబెటీస్ వాళ్ళందరూ దాని గురించి ఆలోచిస్తూ ఉంటారు, దాని గురించి తెలుసుకుంటూ ఉంటారు. టైప్ 1 అంటే ఇన్సులిన్ ఇవ్వాలి, టైప్ 2 అంటే టాబ్లెట్ల మీద కంట్రోల్ చేయాలి. ఇది చిన్న వయసులో వస్తుంది, అది పెద్ద వయసులో వస్తుంది. ఈ టైప్
Great,
2
sir. I
అనేది
think, yeah.
లావుగా ఉన్న వాళ్ళలో వస్తుంది.
Right. So the message is type 1 is usually seen in youngsters less than usually 17 years. Between 17 and 30, there are other types of diabetes also, but that is left to your doctor to decide on whether you are a type 1 or in the type 1, there are subtypes, there are varieties of that. Type 2 is usually seen above 30, 40 years in obese individuals where they're usually controlled by the tablets. Whereas type 1, mostly they are controlled with the insulin. There are subtypes which are also controlled with the tablets, but that is the message. Now, JJ sir, once you are a diabetic, आप जिंदगी भर डायबिटिक रह जाएंगे? Can diabetes can be reversed? उसको रिवर्स कर सकते हैं, क्योर कर सकते हैं? That is a common man's question most of them have, especially when they become detected, they are desperate to convert it back. वैसा कुछ हो सकता है सर?
देखिए, एक बात समझ लीजिए, डायबिटीज हुआ तो हो गया, डरने की बात नहीं है। डायबिटीज क्या है, आपके ब्लड में शुगर है, हर के ब्लड में, हम चारों के ब्लड में शुगर है बाबा, आपका थोड़ा सा ज्यादा हो गया, डरो मत, कुछ चीजें करो, डाइट कंट्रोल करो, एक्सरसाइज करो, आप ठीक रहोगे। आगे बात करते हैं व्हाट आर द वेरियस कॉम्प्लिकेशंस ऑफ डायबिटीज। कमिंग बैक टू योर क्वेश्चन, आपका जो मुद्दे का सवाल है कि डायबिटीज को रिवर्स कर सकती है कि नहीं, ये भी मेरे हिसाब से जनरल पब्लिक के लिए थोड़ा सा डिफिकल्ट सवाल है। आई थिंक टेक होम मैसेज आप लोगों के लिए है कि एक बार डायबिटीज हो गया तो जिंदगी भर के लिए आपको नियम करना है, डाइट कंट्रोल, एक्सरसाइज, हम लोग आगे बात करेंगे। लेकिन हाँ, देर आर सर्टेन काइंड्स ऑफ डायबिटीज विच यू कैन, देयर आर टू वर्ड्स विच वी कैन फाइट ऑन, वन इज कॉल्ड रेमिशन एंड वन इज कॉल्ड रिवर्सल। रेमिशन मतलब हमने ढक्कन देके दबा के रखा है लेकिन अंदर है, और रिवर्सल का मतलब पूरा का पूरा निकाल दिया, तो थ्रो इट आउट कंप्लीटली। Now this is a controversial issue in our literature as well, in complete diabetes literature. Generally अगर आप बहुत मोटे हैं, ओबीज हैं, ये BMI हम लोग बोलते हैं, वेट और हाइट को मैच करके, मान लीजिए आपका BMI 35-40 है, 35-40, and there if you lose weight dramatically, then probably you might be able to reverse your diabetes completely. But those are rare exceptions. Majority of the times हम लोग दवाई देते हैं, दवाई दे करके ऐसा होता है कि आपने 3-4 महीने दवाई लिया, उसके बाद शॉर्ट विंडो पीरियड में आपको दवाई नहीं लगता है, दैट इज जस्ट कॉल्ड रेमिशन। आगे चल के आपको फिर दवाई की जरूरत पड़ेगी। सो इन शॉर्ट आंसर टू द क्वेश्चन से डॉक्टर श्रीनिवासा, अगर डायबिटीज है तो मान के चलिए कि आपको डायबिटीज जिंदगी भर रहेगा। डायबिटीज कोई मतलब कि खराब चीज नहीं है बाबा, थोड़ा सा शुगर ज्यादा है, नियम करना है, नियम नहीं करेंगे तो वो खराब रूप धारण कर सकता है, और रिवर्सल हो सकता है, लेकिन उसके पीछे भागिए मत, आप नियम करिए, डायबिटीज को कंट्रोल में रखिए। कंट्रोल इज द मोस्ट इंपॉर्टेंट वर्ड, रिवर्सल रेमिशन से ज्यादा कंट्रोल, दैट इज द मोस्ट इंपॉर्टेंट वर्ड। आई विल स्टॉप हियर, आपके बैक।
ग्रेट सर। सो अभी इस सवाल आप दवाई के बारे में उठाए सर, तो ये दवाई जब एक बार शुरू हो जाता है वो जिंदगी भर लेने का जरूरत है?
जनरली दवाइयों में देखिए, अब इस तरीके से स्ट्रेट उत्तर देना मुश्किल है, तो वी हैव टू गो लिटिल बिट मोर इनटू डिटेल इसके बारे में। जनरली अगर आप कोई भी गाइडलाइन देखें, अगर आपको डायबिटीज होता है तो दवाई बाद में आता है। सबसे पहला चीज है लाइफस्टाइल मॉडिफिकेशन। आप मेरा कोई भी प्रिस्क्रिप्शन देखिए, उसमें लिखा रहेगा प्रोफेसर LSMG का नाम, लाइफस्टाइल मॉडिफिकेशन। आपको डाइट कंट्रोल करना है और आपको एक्सरसाइज करना है। इसके साथ एट द वेरी ऑनसेट मेटफॉर्मिन करके एक दवाई होती है जो इंडिया में 50-60 डिफरेंट नाम से बिकती है, दैट हैज टू बी स्टार्टेड। आगे चल के हम और बात करते हैं अबाउट मेडिकल ट्रीटमेंट एज टू व्हाट इज अर्ली कॉम्बिनेशन थेरेपी, स्टेप वाइज थेरेपी, उसमें बाद में आते हैं। तो जनरली अगर डायबिटीज हो गया, हाँ देखिए, कुछ डायबिटीज में लाइफ लॉन्ग दवाई की जरूरत नहीं है, जैसे डॉक्टर राव बता रहे थे, GDM, जेस्टेशनल डायबिटीज मेलिटस, दैट इज कम्स ओनली ड्यूरिंग प्रेगनेंसी, दैट इज द टाइम व्हेन यू डू लाइफस्टाइल मॉडिफिकेशन, टेक इंसुलिन और नो इंसुलिन। After GDM is over, then you do not take any medication, but you still need to follow up yearly as we discussed, क्योंकि आपका आगे चल के डायबिटीज डेवलप करने का बहुत ज्यादा रिस्क है इन महिलाओं में। मान लीजिए आपको ड्रग इंड्यूस्ड डायबिटीज होता है, जैसा आजकल हो रहा है कोविड के माहौल में, पीपल आर गेटिंग हाई डोजेस ऑफ स्टीरॉइड्स, And many people are getting very high blood sugar values. Some of these are only what's called chemical diabetes, medication induced high blood sugar. They are requiring high doses of insulin, लेकिन आगे चल के उनको फिर दवाई की जरूरत शायद नहीं पड़े. But these are exceptions like GDM, steroid induced diabetes. Generally आपको अगर type 1 diabetes हो गया तो आप ध्यान रखिए इंसुलिन भूल करके भी बंद नहीं करना है. लाइफ लॉन्ग इंसुलिन लेना है. इंसुलिन के बारे में बहुत बातें कर सकते हैं हम लोग, बट डू नॉट स्टॉप इंसुलिन इफ यू आर टाइप 1 डायबिटिक. टाइप 2 डायबिटिक में मेटफॉर्मिन आपका साथी हो गया अनलेस एंड अनटिल देयर इज अ कॉन्ट्राइंडिकेशन. कभी कभी होता है, जैसे आई वेरी फर्मली बिलीव इन व्हाट्स कॉल्ड इनिशियल कॉम्बिनेशन थेरेपी, डॉक्टर श्रीनिवासा. तो इनिशियल पार्ट में आई हिट हार्ड. जैसे घर में आग लगी है, दमकल बुलाइए, गेट फायर ब्रिगेड, गेट द फायर doused very quickly. So I may start with 3 or 4 medications in the initial part, and then as soon as I get control quickly, I may reduce. मैं दवाई थोड़ा कम करूंगा, लेकिन बंद करने की नौबत बहुत rarely आती है. Most of the times you will definitely continue on metformin. So I'll stop there. We can continue.
Yes, sir. The treatment is basically individualized. You need not panic. Your doctor will decide whether 1 drug, 2 drugs, or 3 drugs are insulin. So please do not panic. Sir, Rao sir, the next question to you, sir. Now, what do you think the family support or the emotional support by the family members and the lifestyle issues, what is your take on that, sir? How important it is for a newly detected diabetes?
In the case of children with diabetes, in type 1 diabetes, it is almost essential that we should have family support. That's very essential. The mother and father are always worried about their child. It's almost like unavoidable. Without a family support, you cannot look after a child with diabetes. So we have to counsel them and train them a lot. That's very important, especially in children with diabetes, whatever their age may be, whether they're below 15 years or below 12 years or below 10 years. At any age, a child with diabetes requires a lot of family support, and we all realize that. And most of the time, the doctors counsel the parent more than what they do to the child, and that's very important. And the child should not feel that he or she is being pampered. That's also very important. So that kind of counseling, there's very strict guidelines for treating a diabetic child with the medication, and also to avoid emergencies. All these things should be taught to the parents of the child. That's very important. And coming to the type 2 diabetes is also a serious issue. The moment the person is known as a diabetic, diagnosed as diabetic, there is an initial shock, there is an initial denial. The person, an adult with diabetes for the first time, when he was told that he has diabetes, they try to deny it. They try to go to another doctor or go to another lab and reconfirm it. So there is an amount of some delay in starting the medication, whether it is non-pharmacological or medication. There is some delay because the person doesn't want to believe that he has diabetes. So that makes a lot of problems. As much delay causes a lot of complications at that time or even at a later time. So early initiation is early initiation of the drug is what we all advise mostly. So there in that situation also family should be made aware of the diabetes. If the doctor knows that a person in his clinic is found to be diabetic and that person is not taking treatment as advised by him, then the doctor should take steps to talk to the parent, the wife and siblings, even the siblings. Or even the grown-up children, if they have grown-up children. And then they have to take the support of the family and convince the family to help the person with the newly diagnosed diabetic to start treatment as early as possible, and also further investigations, whatever is advised by the doctors. So family support is almost essential for both type 1 diabetes in children and type 2 diabetes in adults.
Great, sir. Thank you very much for that message, sir. Now, Dr. JJ sir, about the follow-ups, how frequently a patient should visit to a doctor, minimum or maximum in a year, in a month? How do you decide on that? And what is the basics they should follow when they come back? What kind of tests they should do? Or glucometer usage? Just about short answers for these kind of questions, which lot of people have got when they're newly diagnosed.
We need to just classify what kind of diabetes we're talking about. As Professor Rao
Mostly
said,
type 2. Type 2,
we're
as I
talking about
say.
type 1
2.
diabetes, very small percentage, 5% is type 1 diabetes. Having said that, India is one of the largest population of type 1 diabetes. I leave that. We will focus on type 2 diabetes.
Type 2 diabetes.
See,
Yes.
once you're diagnosed with type 2 diabetes, pehli baar, the first time you visit, you will have a lot of apprehension, lot of questions. I think, as Professor Rao said, come with a family member. The first visit is mostly education, mostly letting you know what diabetes is all about. So you sit with the more with the dietitian, more with the diabetic nurse to learn all these things that we are discussing as to what is diabetes, what kind of diet you should take, how much of exercise you should do, whether you should be buying a glucometer to monitor your sugars at home, or you don't need to do that. And then after having this visit, you will come to the doctor. The doctor, as I mentioned previously, most of the time will start some medication depending on what is your HbA1c value at presentation. Also, we see other things, as to what kind of diabetes you have, whether you have any contraindications or indications for a particular kind of medication, whether you have any underlying condition, as we call comorbidity now in these COVID times, that will have an effect on our choice of medications. Then the next follow-up will depend on how bad is your diabetes. Like I see some people presenting with a fasting of 128, PP of 210, and HbA1c of 6.8. So they've been caught early. Their beta cells are not that, they're still stressed, but not that stressed. Here, probably I'll be starting 1 or 2 medications, and probably I'll be saying, come back to see me after 2 months. And once I get you steady, probably you will be asked to follow up once every 3 or 4 months. The things to monitor is definitely once a year. We did not discuss this, Dr. Srinivasa. The whole purpose of treating type 2 diabetes, of course, is to acutely जल्दी से शुगर घटाना so that आपको infection वगैरह ना हो. But the main idea of treating diabetes is to prevent long-term complications. The sugar per se doesn't give you much problem. As Professor Rao mentioned initially, that so many of us, हमको पता भी नहीं है कि sugar ज़्यादा है. So we are asymptomatic. कोई symptom नहीं है. So that's why you should be treated to prevent complications, and complications we generally divide into based on the blood vessels in the body. If they're small blood vessels, we call microvascular, and if they're thick, big blood vessels, we call macrovascular. तो मैक्रो में आपको 2 चीज को ध्यान रखना है, 3 चीजें होती हैं, 2 ध्यान रखिए, एक है हार्ट, एक है ब्रेन. स्ट्रोक होने की संभावना ज्यादा है, एंड यू हैव अ हायर रिस्क ऑफ हार्ट अटैक्स.
कितने ज्यादा रिस्क होते हैं सर एक डायबिटीज को हार्ट अटैक होने का कंपेयर टू अ नॉर्मल आदमी से?
डिपेंड, बहुत चीजों पर डिपेंड करेगा. इट डिपेंड्स ऑन द ड्यूरेशन ऑफ द डायबिटीज, साथ में और कौन सी रिस्क फैक्टर्स हैं.
माय क्वेश्चन इज जनरली 3-4 टाइम्स मोर, 6 टाइम्स मोर,
2 to 4 times depending on the other comorbidity. 2 to 4 times risk of what we call cardiovascular disease, CVD, and the risk of heart failure varies from study to study. Like that also is anywhere from 40 to 60% higher risk of heart failure. So yes, follow-up would be definitely once a year. You should visit a center where you get screened for complications. That is, have your eyes checked कि retina में कोई damage तो नहीं हो रहा है. Have your kidneys checked. Kidney checking is very simple. One blood test for creatinine and just looking for whether you're having any albuminuria. आपके पेशाब में थोड़ा सा प्रोटीन निकल रहा है कि नहीं. Have your feet checked. See, diabetes के लिए हम लोग we take very good care of our eyes, we take very good care of our face, we take very good care of our teeth, but we forget our feet. For diabetic people, feet are very important because blood supply, nerve supply gets damaged. We can come to the discussion later. And then once a year, get an ECG done to see if you're getting any changes in the resting ECG, and follow up with the doctor every 2 to 4 months. If you're good control, 3 times a year is more than sufficient. And if the control is bad, then of course doctor may keep calling you every 2 months, 4 months. Especially if you present with sugar of, say, the other day I saw somebody fasting, sugar was 280, PP sugar was 540, HbA1c was 14.5%. First presentation of type 2 diabetes. Now in this case, I will have to start the patient on insulin. इनको insulin शुरू किया. अब insulin शुरू करने के बाद I can't call him back after 2 months or 4 months. I'll probably be seeing him 1 week, 2 weeks later, get him used to the insulin, get the sugars down a bit, and then we fall on this longer follow-up periods. Back to you, Dr. Srinivasa.
Right, sir. I'm audible, sir?
Are you audible?
Yeah. So in relation to that, I've got one question because you're from West Bengal, so I'll ask in Bengali. So diabetes ধরা পড়লে কি প্রথমেই ইনসুলিন নিতে হতে পারে? So
अरे
the
वाह
question I'm
डॉक्टर
asking, the question I'm asking Dr. Mukherjee is it possible that a patient might require insulin in the early stage? So I'll ask the question again, once again in Bengali, and you'll answer in Bengali, sir, because a lot of our viewers are from your
বলুন
state.
দাদা বাংলায় বলুন
So diabetes ধরা পড়লে কি প্রথমেই ইনসুলিন নিতে হতে পারে?
ঠিক আছে, খুব ভালো প্রশ্ন করেছেন শ্রীনিবাস দাদা। আচ্ছা, জোকিং অ্যাপার্ট, ডায়াবেটিস ধরা পড়লে যেটা আমরা কথা বললাম যে যদি টাইপ 1 डायबिटीज হয় তাহলে সব সময় इंसुलिन इंसुलिन इंसुलिन। हिंदी में अगर टाइप 1 डायबिटीज है तो आपको इंसुलिन लेना है लेना है लेना है, बंद नहीं करना है नहीं करना है नहीं करना है। যদি টাইপ 2 ডায়াবেটিস হয়, যেটা আমরা আগে ডিসকাস করলাম, টাইপ 2 ডায়াবেটিসে যদি প্রথমবার যখন আসছি তখন যদি আমার ফাস্টিং 250-র বেশি, খাবার পর 350-র বেশি, আমার অনেক সিমটম আছে যেটা প্রফেসর রাও বললো, পলিইউরিয়া, পলিডিপসিয়া, মানে আমার বারবার খিদে পাচ্ছে, বারবার জল তেষ্টা পাচ্ছে, বারবার টয়লেটে যেতে হচ্ছে, তাহলে ডাক্তারবাবু কিন্তু প্রথম 2, 4, 6, 8 सप्ताह इंसुलिन देवे। हिंदी में अगर आप टाइप 2 डायबिटिक हैं और आपका फर्स्ट प्रेजेंटिंग शुगर बहुत ज्यादा है, फास्टिंग 250 से ज्यादा, पीपी 350 से ज्यादा है, या जैसे प्रोफेसर राव ने बताया अगर आपको सिम्टम्स हो रहा है, बार बार पेशाब लग रहा है, भूख प्यास लग रही है, बहुत वजन घट गया है, जिसको हम लोग बोलते हैं कैटाबॉलिक सिम्टम्स, तो आपको डॉक्टर साहब जरूर इंसुलिन शुरू करेंगे। घबराइएगा मत, ये इंसुलिन शॉर्ट टर्म के लिए होगा, 2 वीक, 4 वीक, 6 वीक, 8 वीक, 3 महीना, 6 महीना के लिए, ताकि आपका शुगर जल्दी से घटे और आपका जहां से शुगर बनता है, इंसुलिन बनता है, बीटा सेल, उस पे दबाव ना पड़े, ताकि उनको उनका फंक्शन में लॉस ना हो। एंड और इंसुलिन इसके बाद ये छाड़ा टाइप 2 ডায়াবেটিস যখন প্রোগ্রেস করতে থাকে, 10 বছর, 15 বছর, 20 বছর হয়ে গেল, তখন যেখান থেকে ইনসুলিন তৈরি হচ্ছে প্যানক্রিয়াসের বিটা সেল থেকে, সেই বিটা সেলগুলো আস্তে 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 কম কাজ করতে আরম্ভ করে। ইট কামস টু স্টেজ যখন টাইপ 2 ডায়াবেটিকের শরীরে ইনসুলিন দরকারের থেকে কমে যায়, তখন কিন্তু আর ট্যাবলেট কাজ করবে না। যতগুলো ট্যাবলেট আছে একটা বাদে সব ওয়ার্ক থ্রু ইনসুলিন। सो दैट इज द टाइम व्हेन अ टाइप 2 डायबिटिक विल अगेन नीड इंसुलिन। तो एक वक्त आएगा जब आपके शरीर में कुएं में पानी सूख जाएगा, इंसुलिन सूख जाएगा। किसी को 10 साल में होता है, किसी को 15 साल में होता है, किसी को 20 साल में होता है। हर टाइप 2 डायबिटिक को इंसुलिन की जरूरत नहीं पड़ती है, लेकिन बहुतों को विद टाइम जब कुआं सूख जाएगा, अंदर पानी नहीं रहेगा, बाहर से आपको पानी लेना है, तब आपको इंसुलिन शुरू होता है। सो डॉक्टर श्रीनिवासा, बैक टू इंग्लिश, two reasons to start insulin in type 2 diabetic. If they come at present with very high blood sugars, as I said, 250, 350, or if they have catabolic symptoms, then certainly we have to start insulin for a short period of time, and then later on we can withdraw the insulin and go back to OHA. Or a type 2 diabetic gets burnt out, they become insulinopenic, uske sharir mein insulin keeps declining over time and they become insulin deficient, then later on in their lifetime they might not need insulin. As I said, not every type 2 diabetic needs insulin, but quite a big chunk of them end up being on insulin after the 10, 15, 20 years of diabetes. So I'll stop here, back to you.
Yes, I think it's a very clear message that insulin, especially when you initially high sugars, it's not going to be permanent, not for rest of your life. Don't panic. Your doctor is the person who's going to decide how long it is going to take. Even in conditions like infections, when you get admitted to the ICU, like COVID example, in the ICU, we give insulins temporarily for 4 or 5 days to a patient and they discharge him on tablets most of the time. So do not panic. Sir, coming to you, sir, Rao sir, about medications, can you briefly tell us, the people have apprehension about side effects of the drugs when they say, because most of the patients think allopathy medicines is end of the story, your kidneys get damaged, your liver get damaged. This is what the common perception many of our patients have about the drugs, the oral hypoglycemic drugs, what we call. Few words about the drugs and the safety part of it, and the importance of adherence also, sir.
I tell my patients for this kind of question. So I tell them that the most common medicine what we are using in diabetes is metformin. The first line of medication in diabetes is metformin. Almost on the first day of diagnosis of diabetes, we start them on metformin. And I tell them metformin is introduced to India in 1950s, almost 70 years back. And we have been using almost every country in the world, every diabetic in the world is using metformin, and we have large. And in India, we have more experience with metformin than any other country, and we make more metformin in the country. And metformin is absolutely perfect. There is no complication. There is no problem. Metformin doesn't cause any harm to the person with diabetes, and this is the one for to be more to stress to put some sort of a emphasis on what I'm telling. I tell them that this is the only surviving medication, allopathic medication in the history of pharmacopoeia, at least in India, for 70 years. No other medicine has survived for 70 years in India. So such a long history with the largest number of people being treated on metformin, and it doesn't cause much harm. So we tell our patients that without any apprehension, they have to start metformin on the first day of diagnosis of diabetes, along with lifestyle management. That's also there, but we have to start metformin. So we tell them that it is the safest medicine, and nowadays, almost all medicines, second line and third line medicines, are being given in combination with metformin. Fixed dose combinations are popular medications in India. Almost all medicines used in India nowadays are given along with metformin. So metformin is such a safe medication. So they should not have any apprehensions about that. The second common medication which we in India use is sulfonylurea. Sulfonylurea, right now we are seeing a lot of glimepiride. Previously there was glyphosate and glibenclamide. Now the glyphosate is still there, and then we have glimepiride. And the sulfonylurea, glimepiride also is introduced long ago, almost 50 years back, and we don't see many bad effects. Glibenclamide, the dinyl, used to have some problems earlier. Now it is no more available in the market. So we have mostly the glimepiride, and combination of glimepiride with metformin is the commonest fixed dose combination used in India. Both of them are safest, and they have a history of 50 to 75 years. And they have been in the market for so long, and people have been using it, and there's absolutely no fear. Sulfonylurea are hypoglycemic, so we also give them a caution that we should not take more than what is given to them by the doctor. No, doctors, previously there was a lot of controversy that sulfonylurea causes heart problems. They say that a lot of other issues are also there, but all those things are gone. Way back in 1960s and 70s, they used to think sulfonylurea cause heart problems, but that is no more the issue right now. Sulfonylurea and metformin are absolutely safe. There's absolutely no problem. There are other classes of medication with good.
We'll come back to that, sir. We'll come back to the other class of drugs, sir. Dr. JJ, we are talking about something called hypoglycemia or low sugar. Now, one of the dreaded complication which a patient, they will never forget their first episode, we say, of their symptomatic hypoglycemia in practice. So what is your take on that, sir? What is hypoglycemia? How do you prevent? And when somebody has got, what they should do? So, in a few words, can you please brief on that, sir?
See, this is like explaining to the patient when you buy a car, everything is not good. There are some downsides when you buy a car. You have to fill petrol, you have to get air in the tire. Sometimes the tire might burst. So everything in life, I can go giving more examples, but because there's a large audience, I won't go to the dangerous examples. I won't go into. I think
all of them are married, sir. All of them are married.
There was a nice Hindi picture called "Sadi Ke Side Effects." So I won't go into that. So whenever we start treating something, see, every Newton has said it. Every action has got some reaction. So there will be some effects, and one of them is called hypoglycemia. Now, what is hypoglycemia? Hypoglycemia means your blood sugar has gone below a certain level. By definition, we say that if your blood sugar has gone below 70, you're hypoglycemic. Now, as blood sugar keeps going down, the problem is the only fuel which your brain can take is glucose. Your heart, your muscles, they can take some other fuels, but brain only survives on glucose. So as the glucose keeps going down, you start developing some symptoms. See, body has got a defense mechanism. The moment the glucose starts going down, a lot of defense mechanisms come to pop up this glucose value. These are called all the hormones. The question on stress. So when you get stressed, these hormones come out. cortisol, adrenaline, noradrenaline. They will try to pop up your glucose. And this adrenaline and noradrenaline give certain symptoms. That's good, that's protective. These symptoms are you start profusely sweating. That's what I tell my patient. The first thing you should think about, you should notice is profuse sweating, and then your heart starts pounding, palpitation, boom, boom, boom. So sweating, palpitation, and then you start feeling hungry, profound hunger you get. If you are missing these, then you start to get a little bit of what's called brain getting less glucose, and you start getting the neurocognitive, means brain effects. They also develop slowly. You have time. There's a little bit of confusion. There's a little bit of difficulty in thinking, getting your thoughts properly. After that, you may start slowly slowing down, losing consciousness. So you should be aware that whenever you do something, there may be a side effect. Hypoglycemia does not happen with all the medications. Metformin, as Professor Rao said, is very safe. Very, very, very rarely causes hypoglycemia. The newer medications, which we will discuss if we have time, they also cause hypoglycemia very rarely. So hypoglycemia generally happens with two classes of medications. One is sulfonylurea. As Professor Rao said, I totally agree with him. They're very safe. There's a whole lot of data. They're very cheap. But this is the downside. They may cause hypoglycemia. Suppose you miss a meal, or you eat less, or you delay a meal. So there's always a reason for that. Or sometimes if your kidney starts under functioning, underperforming, then you may get hypoglycemia. So hypoglycemia is nothing to be too scared of, but you should not take it lightly. That's why when the patient is diagnosed with type 2 diabetes, especially type 1, because insulin is the very, very well known to cause hypoglycemia, there should be some time spent. The doctor and the nurse and the dietitian spend some time with you, explaining to you about hypoglycemia, explaining to you about these symptoms. If these symptoms happen, treatment is very, very simple. Thus, 15 gram of glucose, whichever form you want to get it. Orange juice, 3 spoons of sugar, 3 spoons of Glucon-D. There are some tablets now which are not easily available. So you just carry some form of refined sugar with you. 3 spoons will get you back. All the symptoms will disappear. But mind you, you need to eat something after that. Just don't rely on those 3 spoons of sugar, because after 15-20 minutes, the hypoglycemia may recur again. So once you take those 3 spoons of sugar, the hypoglycemic symptoms are gone. You're now thinking straight, sweating, palpitation has stopped. Please eat something, whatever you can find, biscuits, cakes. If your meal is due, lunch or dinner, have your lunch or dinner. So, Dr. Srinivasa, I can go on. Shall I stop here?
No, I think the message is very clear, sir. The hypoglycemia, you describe the symptoms very nicely, but the point, very important point you emphasize is that the culprit is most of the times it's a lifestyle related. Either you have skipped, or you are over exercised, you have delayed your meal, or you take an extra dose of a tablet or insulin inadvertently. So these are the points we should analyze always whenever you have hypoglycemia. There has to be a reason. So that is very, very important message I think that J.J. Mukherjee has given us. So far we have discussed about the symptoms, who are the people who are at risk, how do you diagnose, how frequently you monitor your sugars or visits to the doctor, how frequently you check, and we touched upon few complications. What are the complications like micro, the large vessel, or the small blood vessels complications, the heart attack, stroke, what is the percentage of risk? And we have spoken now about 2 classes of drugs. Now, the PV Rao sir, what are the other classes of drugs, especially the newer ones? They say they're very costly medications. The patients think it is very costly, so there can be alternative to that, the cheaper medicines. So how do you weigh what the cheaper so-called sulfonylureas, metformin classes versus the newer class, we call it as DPP-4s or SGLT2, the cost-wise, because ours is an out-of-pocket market. What is your take on those class of newer medications?
Last few years, American Diabetic Association is also encouraging us to consider the cost factor while deciding on anti-diabetic medication. Earlier, it was the discussion was mostly to avoid hypoglycemia, to avoid weight gain, and also to look for the benefits on the heart and the kidney. So those are the considerations for deciding on anti-diabetic medication according to American Diabetic Association. But now that a large number of people in the world belong to the lower socioeconomic group, so they are also included. While considering an anti-diabetic medication, we should also think about the cost factors. So sulfonylureas were included. Previously, sulfonylureas were not in the second line or third line, but now metformin and second line is sulfonylurea. Then they also given pioglitazone, the glitazone. There's a third line drug. So glitazones are also not as expensive as the current most expensive medication. So there was a lot of problem with the glitazones earlier with rosiglitazone and other glitazones. But now the pioglitazones are now safe. So pioglitazone, sulfonylurea, and metformin are considered as a safe medication and cheaper alternative anti-diabetics for populations from third world countries or from developing countries or from the lower socioeconomic countries. So, weighing the cost benefits of this low cost anti-diabetic with high cost anti-diabetic, in my opinion, the best thing is that the protection against heart and kidney. So they always prophesize that the new anti-diabetics, which are very expensive, 45 to 70 rupees a tablet, they have a protective effect on heart and kidney. Ultimately, we are treating diabetes for preventing heart and kidney diseases. We are treating diabetes with blood sugar control vigorously with a single objective of avoiding heart and kidney problems. So they say that anti-diabetic medications, the current anti-diabetic medications, those are expensive. For example, the gliflozins, the DAPA, Kana, and EMPA, which are very expensive. But they say that these medications actually benefit in reducing the secondary complications of diabetes like heart and kidney. So considering their protective effect on the heart and kidney, they say in spite of being costlier, we may have to consider these medications to the low cost medication if your patient can afford,
Right.
and if other ways of managing the cost issues.
Thank you, sir. Thank you. Dr. JJ, your take on these newer class of drugs, are they really helpful or should we put for most of our patients? What is your take on this, sir?
See, I think I would go along with Dr. Rao, Professor Rao. It's like you going to see a movie, okay? Depends on which part of the movie hall you want to sit. If you can afford, you take the gold class ticket. If you cannot afford, you take the silver class ticket. And if you cannot afford it at all, like when I was a student, I used to sit in the front row, you see, and watch like this, with my neck up like that. So
we call it Gandhi class.
so everything, you see, same thing if you want to buy a vehicle, say, I mean, let's say a motorcycle or a cycle or a car. So it's cost effectiveness. So if cost is an issue, which I totally agree with Professor Rao, ADA never had that column. They now have that column. 2018, first time they have this cost sensitive column. So if cost is an issue, all my people who are listening to me, do not think that you're being cheated. You're not getting the better medicines. With good control, with good blood pressure control, with good cholesterol control, give up smoking, moderate your alcohol intake, exercise 30 minutes a day, you can still get the benefit to the heart and the kidney. So don't go home thinking that if I don't see the movie sitting in gold class, I've not seen the movie. I mean, as a student, I used to sit in the front row, still see the movie, had a sore neck. That was the only problem. That was the only problem. But of course, Dr. Srinivasa, Professor Rao, if somebody can afford, then certainly the newer classes of medications are an advancement over what I grew up with when I was a medical student. We had metformin, sulfonylurea, pioglitazone, human insulin. Pio came later. But now the newer classes of drugs, which Professor Srinivasa mentioned, DPP4 inhibitors, there are quite a few drugs in there. And many of my patients, if they're online, they know. I gave a lot of sitagliptin, vildagliptin, other gliptins to them. And the second group is SGLT2 inhibitors, a few molecules in this group. And the third one is an injectable called GLP-1 receptor agonist. See, the advantage of these newer classes, like any newer model of a phone, iPhone 6 versus iPhone 10, cost goes up, but then there are added benefits to it. So there are certain added benefits of these drugs. Number one, they do not cause weight gain, if at all. SGLT2, GLP-1 help you lose weight, not in everybody. I mean, experience varies from all our specialists in our country, but anywhere between 20 to 60% of people will lose some amount of weight when they go on to SGLT2, GLP-1. Second is they provide the cardiac protection and kidney protection. First and foremost, let's not get it wrong. We have to get our diabetes control, get our HbA1c tightly controlled, get our blood pressure control, get our lipids control, get the patient off smoking, moderation of alcohol, exercise. On top of that, once you've got the two, three layers of your cake. These newer medicines certainly add on. There is no doubt about that. In the last decade, there have been, we call them cardiovascular outcome trials. So the cardiovascular outcome trials have given us a lot of information that on top of this standard of care, we call SOC, standard of care, what I just discussed, on top of this, if you add an SGLT2 inhibitor, empagliflozin, dapagliflozin, canagliflozin, those of you who are listening, who are using these drugs will appreciate what I'm trying to say. Or if you can afford, really afford, they're very expensive, the GLP-1 receptor agonists, injections like liraglutide or dulaglutide, then you get added the benefit with regards to cardiovascular mortality, dying of a cardiac condition, developing heart failure, and worsening renal function. So in a nutshell, the older drugs work. There was a nice big trial called Steno-2 trial, which showed that if you take collective management, you can get all the benefits. But the newer medicines definitely over the last decade are an advancement. But unfortunately, they come with a cost attached to them, as Professor Rao was saying. So I will let you decide. When you come to my clinic, I always give this option to the patient. I say gold class, silver class, or like me as a medical student, front row. I'll go back to Dr. Srinivasa.
Yes, sir. Thank you, sir. I think we commonly say a good student do not require a tuition classes, extra tuitions it doesn't require. So if you control your sugars with your diet and exercise, a simple metformin can help you. It's not that we are going to prescribe this medicine to every other patient. It's only with a high risk category, we categorize them and then initiate these drugs called SGLT2 or a GLP-1s. So if you are a good patient, your parameters, your kidney functions, you have no complications, the high disease or your ECG is normal, treadmill test is normal, then I don't think you require any of these drugs. So the message is very clear. Sir, yes, sir. Yes.
Can I intervene? I think we cannot say that you do not require, you see, because that is going.
No, when it's well controlled with their lifestyle modification.
No, even if they're well controlled, but they have these conditions, like if they already have what we call as atherosclerotic cardiovascular disease,
the risk stratification, what we call,
in layman's language,
based on your risk.
If you already had a heart attack, already have had a small stroke, or the blood supply in your feet is less, or you have heart failure, or your kidney function is below a certain is affected. In these people, I think it is our duty.
It is a must. It is a must.
Any doctor you go to will tell you about these medicines. He is duty bound to tell you about SGLT2, GLP-1. After that, the choice becomes yours. It's individualization. The patient has to decide whether he or she can. I mean, there's no point, telling me, to go to, buy something which I can't afford. But I should at least be made aware of that this thing is there. This may reduce your kidney progression of kidney failure or cardiac issues. So these 3-4 conditions, I think it's duty bound. The doctors will discuss with you, and after that, if you can afford, because I have experienced both ways. You see, I have people who can afford the drug, easily afford the drug, but they still don't take it. So that situation, I think we should. I think as doctors, we should push a little bit hard. But on the other hand, as Professor Rao, I totally agree with him. No point reading a guideline textbook. A person comes in front of you who can't afford 100 rupees per day for a medication, prescribing him an SGLT2 or DPP4 may not be the right thing to do.
True, sir. I completely agree, because there are guidelines which are very, very clear-cut. People who have an established heart disease or a kidney disease, these drugs have to be initiated. But it depends on the case-by-case basis, because in our country, we have to think about the out-of-pocket affordability of our patients, and that is how you take a call. But it's our bound duty to explain and probably document. I definitely document in my practice that this class of drug was advised and the patient denies for these reasons. So it's very, very clear. Now, finally, sir, about insulin, a lot of patients, especially newly detected patients, I think we have already discussed this point. Again, should we emphasize that insulin is one of the safe drugs, because a lot of patients think once you start insulin, it's the end of your life, your kidneys get damaged. This is a very, very common perception people have. Sir Rao, sir, what is your take on this, sir? Or your advice for the viewers?
I have also been hearing about this insulin being harmful to the kidney. I don't know from where this particular idea has come, but even in my own practice, people have been asking me. I have not known any reason why anybody should associate insulin with kidney disease. But somehow, off late, I've been hearing more and more such questions. Insulin is something that protects. Basically, insulin is the ultimate treatment for diabetes. So most of the time they may be able to manage with tablets, but sometime during the progression of the disease, they may have to go for insulin for better control of diabetes and also for better management of diabetes to prevent the cardiac and renal complications. So they have to, they should not. Doctors should be able to convince the patient to start insulin at the earliest moment whenever it is required, and that may take some time. There is some resistance from patients because it is a painful injections. Plus, it's also more expensive than the tablets. So, but we should be able to convince them. And ultimate thing is that the insulin will manage diabetes complications. It will prevent diabetes complications, and you should be able to. We should be able to give that kind of idea. They used to say that insulin causes cancer. So sometime back, that particular issue is now sorted out. There is no more cancer issue. As earlier, there was a heart issue. People on insulin were developing heart problems. That was a discussion at one time. Then cancer has come. Now, for some reason, people have been talking about kidney, but actually, it's a kidney protection. And anybody with creatinine more than 1.5, urea more than 90, and then blood pressure 160 by 90 with a irreversible renal disease, they should be on insulin plus tablets if they want. So insulin has to be given in any renal disease. So we have to somehow impart this particular information to all our diabetic subjects.
Thank you, sir. I think it's a very clear-cut message. In fact, insulin is the only choice of drug for kidney failure patients. It's not the other way around. Insulin will not produce kidney failure, and if you have kidney failure, insulin is the drug of choice. Now, Dr. JJ, for you, another tricky question about the generics, so-called the cheaper drugs versus the branded drugs. Now, a lot of patients come on these. They ask, that is 40 rupees and this is 5 rupees or 10 rupees. Now, why don't I take this drug? What is your comments on those, sir?
Again, I think my simile of going to the movie hall. What ticket you want to sit in?
Time it's a different movie, sir. Not the same movie.
No, I have seen a couple of movies 3-4 times. Sholay.
Okay.
So depends. You see, I mean, in Bengali, the Bengali audiences who are listening would know Sostar dos abosta. Swasta dos abosta in Hindi means you go cheap. It comes with something attached to it. Attached to it. So certainly, if you are looking for blood sugar control, all the cheaper brands that you're talking about for DPP-4 inhibitors, for SGLT2 inhibitors, insulins are not that different. In fact, the generics and the branded insulins are almost the same price, but the tablets there's difference. So if you're talking about blood sugar control, most of them are equal. Now, if you're differentiating the generics from the branded, the cost difference is huge. So sometimes the cost is as much as 30 rupees per day. What you have with the branded is they have run the race. This car has run the laps in the Grand Prix. You know it can do the Grand Prix. You know it can go to the finishing line, and you know that the tires won't burst. You know the petrol won't run out, and you will finish the race. So that is the difference. And the other car which you are riding in, it may finish the race, may do it slowly. You might have some issues along the line. So in medical parlance, scientific terms, it's called evidence. It's called cardiovascular outcome trials. So the other molecules have done this hard work. They've run the race and they've shown the DPP-4s, the branded ones, they're safe cardiovascular wise. Whereas the cheaper brands, they know that they can run. But whether they can finish, we don't know. What is the cardiovascular safety, we don't know. Do we need to think that they will be bad? Probably no. Probably they will finish the race, but they haven't run the race. Same with SGLT2 inhibitors. You take EMPA, CANA, DAPA. They have done a CVOT and they've shown the heart benefit. They've shown the kidney benefit. The others, the cheaper ones, at the moment, the lot in DPP-4 market, there's one in the SGLT2 market. They have shown that they can get the blood sugar control. They've compared with the branded ones. But as I said, Hindi mein there's a lambi race ka ghoda. So they've run a couple of rounds, but whether they can run the lamba race. So if cost is an issue, then probably you might want to use a generic. But if cost is not an issue, or you are a stickler who wants to follow the evidence, then probably the original molecules take precedence. This is a difficult decision. This is always a personal choice. It's like Sita Swayamvar, my friend. You have to choose.
Thank you, sir. Thank you very much. I think the final question, sir, to Dr. Rao, sir. Sir, a few words about RSSDI initiatives, about this angle, what the programs we have, sir.
RSSDI has been getting into the public education programs in a large way off late. Earlier, it was not like RSSDI was supposed to be a purely research organization, but now we are trying to translate our research findings to the public also. That is the main motive. So, you see, all these social media aspects are very. I appreciate all the new efforts taken by the younger generation. We have seen the younger people taking up the social media. I'm very happy, and RSSDA is always behind the screen for all these excellent social activities being conducted for improving the public health system in India for diabetes management. That's very important. Thank you so much.
Thank you, sir. Thank you. I think with our current president, Dr. Bansi Sabu, and Dr. Sanjay Agarwal, and the social media team, we are doing a great job. At least we are sharing our knowledge to educate few of the patients and few of the general public. I think our purpose is served. I sincerely thank you, sir, for your knowledge sharing, and Dr. JJ Mukherjee for showing us the movie 2-3 times without any ticket. So thank you very much, sir. Kind of you. Over to Purvi.
Great, sir. What a session. This was really fantastic. And actually, Dr. Banshi would have loved to be here, and Dr. Sanjay too, but there was an emergency which he's attending to, so he's unable to join us. So I just wanted to say that, your company, your professorial company, has been of great value and learning to us. And on behalf of the RSSDI social media team and RSSDI core national team, also, I thank each one of you, esteemed faculty of today, RSSDI patron, Dr. P.V. Rao, sir, RSSDI Professor Sam Moses Oration Awardee, Dr. J.J. Mukherjee, sir, and our current RSSDI Executive Council member, Dr. L. Srinivas Murthy. Extremely wonderful session, and although we had a theme declared for today, it was literally a master class in approaching the management of a newly diagnosed diabetes patient. So the amount of information that you all covered was simply phenomenal, and we thank you so much for all your time and effort in just getting through this session. The similes, the local language twist, and also the highlight on the RSSDI initiatives and the appreciation for the RSSDI social media team has been very well acknowledged and appreciated. So thank you very much once again, and please stay connected with us. We need your guidance and we need to learn more from you, sir.
Thank you.
Dr. Reddy, thank you for joining in again.
We had to appreciate you, Purvi. Otherwise, you wouldn't relay this program, no?
It's already relayed, sir. I'm not.
Just on a lighter note.
Thank you, Dr. JJ, and thank you, Dr. P.V. Rao. That was excellent. Thank you.
We are still online or offline now?
We are online.
We are
online. Really enjoyed this masterclass.
In that case, a very formal thank you to RSSDI. Thank you to Sanjay for being here, Srinivasa Reddy Murthy for asking those very nice questions, Professor Rao, of course. I mean, sir, only pranam. And Purvi, thank you very much. Thank you. You really anchored this. You got the whole thing very nicely thought, organized. Thank you very much. Really enjoyed. Thank you.
Thank you, sir. I enjoyed this masterclass. Thank you.
Thank you. Take care, sir. Take care. Stay safe. Good night. Good night, all.
Bye-bye.